30 people, and that's a perfect segue for me to introduce our talk. So today, welcome everyone. Today we're celebrating World TB Day, which actually happened on Monday, March 24th, but is important for our Scarborough patient population because we actually see in Scarborough a third of the TB that gets diagnosed in the GTA area. So today we have two special speakers. The voice you just heard was Dr. Jessica Keene. For those of you who don't know Jessica, she's one of our ID specialists who works mostly at the Birchmount, but helps us out at the General. She has her ID and MedMicro training from McGill University. And Jessica is a patient advocate. What she was just talking about, if you missed it, was one of her patients who had a possible diagnosis of TB where the specimen for TB culture was put in formalin by mistake. But being Jessica, not only did she deal with this patient and having to deal with a repeat biopsy to make sure there was a TB culture sent, not in formalin, but she also advocated for radiology to look at their practices to make sure this didn't happen to other patients. So one of the things that I love about Jessica is not only does she advocate for individual patients, but she advocates for change within the organization to protect her patients and future patients. Jessica, as was mentioned at the beginning of these rounds, if you join late, has just diagnosed two people, I feel like, in the last 2 weeks with TB. One of them's been in hospital for over 9 months. So always thinking about tuberculosis, which can reactivate in our patient population, especially if they've been critically ill. And then also joining us today, we are super lucky to have Dr. Elizabeth Ray. Dr. Ray is an Associate Medical Officer of Health through Toronto Public Health. She's led the TB program at TPH since 2005. She's also an adjunct professor at the Dalla Lana School of Public Health at U of T. And of course, is a co-author of the Canadian TB Standards, which we all use to help us know how to treat tuberculosis. She co-chairs Stop TB Canada, which is a national advocacy network for TB prevention. Elizabeth and all her ID and respirologists have a close relationship. I was on call over New Year's, and one of our respirologists had Elizabeth on speed dial to ask questions about how to manage her TB patients without OHIP. So she's been a huge resource for our IPAC division for our ID and respirology specialists. So today we're lucky enough to have Jess and Elizabeth speaking to us today. So I'm going to pass over the mic to Jessica, and then hopefully she'll be able to share her slides. If not, I have them in backup and I can share them.
Thanks,
Jessica.
Raina. I think we're good. I've figured it out. Thank you so much. All right, let me just get it up. And then you guys will be able to tell me if you don't see it. You see the slides? Perfect.
Perfect.
All right. So we're going to start with a case. This is a case that came to me last month. I was actually called about it on the weekend, and I was like, wow, that is so interesting. And it's always like that. It's like they just show up, these cases, out of the blue, and you're always like surprised, like, wow, how did this happen? So this is a 74-year-old man, Mr. Z. He actually presented to the orthopedic surgeon with a complaint of an unstable, mildly painful, warm, and very swollen right prosthetic knee joint. In terms of his social history, he's born in Red Lake, Ontario. He's never lived anywhere else in the world. He has taken some vacations to Europe, China, South America, only 2 to 3 week holidays at a time, hasn't lived anywhere else. He's married with 4 children. His wife is Canadian born. They've never had anyone living in their home from abroad. He did spend 2 weeks in jail when he was younger, and it was in Canada. And he spent his whole life working in Thunder Bay as an engineer, where he's involved in the construction and mining industry. I didn't know where Red Lake, Ontario was, so I had to look this up. It looks gorgeous. It's on the border of Winnipeg. It's known for its fishing, lakes, very beautiful, pristine nature. And it's a big mining industry. So there's mines there, and that's where he spent his time working his whole life. With respect to his past medical history, he does have a history of recurrent low-grade bladder cancer since 2012. He underwent a radical cystoprostatectomy with an ileal conduit on July 7th, 2024. He also has high blood pressure, hyperlipidemia, substantial obesity. He had a lot of weight loss, something like 100 kilograms post-surgery. And he has osteoarthritis, which we'll get into later. I thought it was interesting in his medical history that he has pelvic lymphadenopathy, NYD. It had been noted since 2013, and he had had serial CT on a yearly basis that describes slow progression of the lymph nodes over time. In 2013, when it was first noted, he underwent a left common femoral lymph node biopsy that did not show any malignancy. When he underwent the radical cystoprostatectomy, they had taken out all the lymph nodes along with the bladder and the prostate, and multiple lymph nodes went to pathology in 2024, and they were described as no malignancy, but in each lymph node sample, there were granulomas. He followed up with oncology clinic on a yearly basis, and they continued to observe and said this is not lymphoma. With respect to his orthopedic history, he had both knees replaced due to osteoarthritis. He underwent left Oxford knee replacement in December 2007. That's a partial knee replacement. Then his right knee, he had a right Oxford knee replacement in 2015. It required revision surgery from a partial to a total knee arthroplasty in 2017, and further revision of the right total knee arthroplasty on March 9th, 2023. So going into that a bit more, he had the initial partial right knee arthroplasty in 2015 for arthritis. He continued to have pain in the right knee. So he had change from the partial to total knee replacement in 2017. He did well for a little bit, but he says the right knee was never well, and he continued to have worsening pain, swelling, and instability of the knee. So he underwent x-rays a few years ago that showed loosening of the prosthesis, and he was seen by his orthopedic surgeon and underwent revision of the right total knee arthroplasty on March 9th, 2023. The OR findings from 2023 showed loosening of the tibial and femoral components. The cultures were sent for routine culture only, and they showed no growth. And pathology from the OR in 2023, the synovial tissue said palisading granulomas with necrotic cores. So he went on for a few years, but he continued to have problems with the knee. It was unstable. He described it as achy at the end of the day and constantly swollen. So then he represented in 2025 to our orthopedic surgeon. It was Dr. Rusin, who then saw him in clinic and started a workup. This is the patient who showed up to clinic. You can see that the right knee is very swollen compared to the left knee. There's no sinus tract. The surgical site is healed. It was warm to palpation when I did see him. So our orthopedic surgeon sent off some testing. He had a CRP that was very mildly elevated at 27.9. The right knee synovial fluid was also mildly inflamed, really minimally, 1,237 white blood cells, 85% neutrophils, and no crystals were seen. He underwent CT of the right knee that showed a lucency around the tibial component, consistent with loosening. Whenever we see that on CT, infection is in the differential. He has a large joint effusion and then an irregular patellar articular surface that could be degenerative, but the differential is infection. So this is wonderful. The orthopedic surgeon sent routine culture, which was no growth, but as part of his practice, he sends a TB culture regularly. And so surprisingly, this culture taken on March 10th, AFB was negative, but 2.5 weeks later, TB grew out in culture. And that's when he called me and he said, "Is this real? Is this something?" And I was like, "Oh, I need to see him next week." So I saw the patient. We brought him to the hospital the following Monday, and I explained to him that he has TB. And he was surprised. He's like, how could this happen? You know, I've grown up in Canada. I haven't gone anywhere. This is, you know, not a disease I should get. I don't understand. So it was very interesting, but we went over it, and then he kind of understood and was like, you know, it's true. My knee has, you know, never been right. It's never been right for years. So it was very interesting. The next thing we think about when we make a diagnosis of TB, you know, somewhere, is that we turn to the respiratory respiratory system. So he had no symptoms of cough or any shortness of breath, but I did get a chest X-ray to make sure there wasn't active pulmonary TB. I was pretty comfortable with bringing him in because I had seen already he had a CT chest in December. That was part of his cancer workup, and that was negative. There were no lymph nodes, nothing cavitary, so I didn't feel that he had pulmonary TB at the same time. We did blood work for LFTs, and then we started TB treatment on the same day. He was started with INH, rifampin, pyrazinamide, ethambutol, and vitamin B6, with a plan to treat him at least 6 months and likely longer. He lives in Tillsonburg now, so I called one of my trusty public health nurses, Elizabeth Wilhelm, who helps me out on all these situations. I said, okay, he lives in Tillsonburg and we need to start him on TB treatment. Can you help me? So she did. We had him fill his prescription initially in Scarborough while she located the public health unit in Tillsonburg and got him set up with TB meds there. And I'll start to follow him up actually virtually, just given the distance. We'll follow up together over the next year. The orthopedic surgeon is going to review his surgical plan. It's a bit difficult because he's had multiple knee surgeries, so he wants to see how he starts to do on the TB treatment first before he makes a decision on retaining or removing the prosthesis. So that was an interesting diagnosis of TB, prosthetic joint infection. It's not common, but it does happen. It typically presents with local symptoms such as joint pain and swelling. There can be development of a sinus tract. I think the sinus tract would be a fairly obvious presentation. Development of an abscess, loosening of the prosthesis, as well as constitutional symptoms are all common. Symptom onset can be days to years. Some studies have said, looking at this, the range is about 10 days to 38 years with an average onset of 2 years. For him, I think he's had it for 4 years. So definitely fits there. Diagnosis is made by synovial fluid aspirate or ideally a tissue biopsy, which is more sensitive. Classically, the fluid will show granulomatous synovitis, which it did in our case. Sensitivity for MTB culture of synovial fluid is pretty good, 64 to 79% range, and a tissue biopsy is always better in the 94% range. You cannot rely on a TB skin test. I reviewed studies where, whether this is TB in a prosthetic joint or not, TB tests can be positive or negative, and that does not help you to make the diagnosis. Management for TB prosthetic joint infection is not well established. I sort of did a literature search, and the duration of the TB medication ranged anywhere from a minimum of 6 months to at least a year. In general, people would treat longer if the hardware was retained. I think that might be the way I'm going with this case. Surgical management varied widely, ranging from people who could not undergo surgery to debridement and retention strategies, staged revision, as well as complete hardware removal. In reviewing the literature, it didn't seem to matter so much which option was taken. So whether there was removal or no removal, people generally did quite well once they were placed onto TB treatment. Okay, and that's the case. Thank you.
Okay, so I'm gonna try and share screen now. Okay, did that work?
Perfect.
Okay. So thanks very much for having me. And I got to say, it is a joy to work with the Scarborough TB docs. So that was a really great case to show some of the complexities of not just diagnosing TB, but managing TB as well. So I'm going to talk more about kind of a big picture of what's happening with TB in sort of Canada, Ontario, Scarborough, and a bit about some of the new things that have been happening. So just, this is back to medical school stuff, but just kind of as a reminder. So TB is a slow growing bacterial disease. And we classically think about TB as being in the lungs, but Jessica's case is a really good reminder about in Toronto, about a third of our cases are extrapulmonary, and they can be truly anywhere. TB is airborne, but it's not exquisitely infectious. It's nowhere near as infectious as COVID or influenza, or certainly not anywhere near as infectious as measles. But it's a bad disease. Without treatment, 50% of people die within 2 years. So it really is a critical infection in terms of the morbidity and mortality. And that is why, in the big picture, at a global level, TB is once again the leading infectious disease killer around the world. There's more people that die of TB than die of AIDS, or malaria, or any of the other ones further down the list. And despite being almost entirely treatable and curable, largely because of issues around access to diagnosis and treatment. In 2023, there were 10.8 million people developed active TB disease around the world, and 1.25 million people died of TB. Not because those weren't preventable situations, but because of problems with access. Ending TB is one of the global sustainable development goals. Canada has signed on and made public commitments to end TB as an issue for Inuit Canadians by 2030. So that's, let me count the years, that's 5 years away. And pre-elimination of TB across Canada a decade from now in 2023. So that's a big challenge. The other thing that's really important to recognize, and I think especially in a place like Scarborough, where we truly are from around the world, TB has a terrible reputation because, you know, in other times and in other places, it really was something that would kill you very dead. And partly because of that and the scale of TB, we've often had really, really harsh kind of social controls about tuberculosis. That picture on the left there is from a famous ship called the C.D. Howe that used to sail around Hudson Bay and stop at little Inuit villages, round people up, chest x-ray everybody. And if you were found to have TB, you were not let off the boat. You were shipped down south, thousands of kilometers away usually, to a TB sanatorium. And many of those people never came back. We still have TB as a cornerstone of immigration screening, potentially for very good reasons, but putting it in the context of immigration makes it, you know, a big deal for a lot of people and causes a lot of concerns about being diagnosed with TB. So TB stigma is very real, and it's almost impossible to talk with patients and families without recognizing that dimension of it. Okay, so this is TB rates around the world. So the darker the color, the higher the rate. You can see Canada's in that palest green color. So in the global scheme of things, overall, we do have very low rates, about 5 per 100,000. And the scale goes all the way up to, for example, in the Philippines, the rate of TB is about 630 per 100,000 people. So orders of magnitude difference in that scale of things. And especially in Ontario, Toronto, Scarborough, our TB is hugely driven by immigration. So to a big extent, you can kind of think of who your patients are, where they're from, where they were born, and what the TB rate is in that country of origin, and that's the picture of TB. So we have very big communities from China, from the Philippines, increasingly large communities in Toronto from Eastern and Western Africa. We had a special movement of Ukrainians from the former USSR. So a huge mix, and our picture of TB is very much sort of represents those immigration flows. So this is like zooming in a little bit on TB rates for Canada as a whole. And again, like globally, they're really low, but they've been creeping up for about a decade. And in 2023, we hit over 2,000 people diagnosed with active TB disease. That's the biggest count of people with active TB since the late 1990s. So, very much not headed for TB elimination in Canada at the moment. And like I said, a big part of that is because of immigration or linked to immigration. We are absolutely part of the global TB pandemic. About four in every 5 people diagnosed with TB were born outside Canada, and that's usually where they acquired their TB. They didn't catch it in Canada. The other big group is among people born in Canada is First Nations and Inuit, and especially for Inuit people, that incident rate there, 204, that's what you would see in sub-Saharan Africa, which is crazy that people born and bred in one of the richest countries in the world would have rates of TB like that. So at the moment, TB is very much not an issue of sort of like the general population in Canada. It's almost entirely born outside of Canada, related to migration, or it's Inuit First Nation. And even the people, I'll talk about it later, but even the people who are born in Canada are usually one way or another linked to those two groups rather than being transmission among people born in Canada necessarily. So this is what's happening in Ontario. So zooming in a little bit. So you can see for a long time, we had very steady numbers of people with TB in Ontario, just over 600. And the rates were slowly falling, despite the fact that the population was growing. And then about 10 years ago, the numbers started to go up. And when you look at the counts for 2024, I'm like, okay, that's why all of us that work in TB are so busy, so stressed these days. There's a lot more TB than there was even 5 years ago. So not only the rates, but the counts have been going up. This is those same TB rates put into a map. So the jurisdictions there are the health units. So the map at the top is the whole of Ontario. So what really stands out there is the higher rates in rural northern and northwestern Ontario. So that's also where Jessica's patient was from, Northwest Ontario, which is interesting. At the moment, we have 4 active TB outbreaks in First Nations communities. All of those communities are in northern northwestern Ontario. And then if you sort of look at the blown up part, that's Southern Ontario. I put a red arrow to where SHN is. And the higher rates in Southern Ontario are pretty much a map of immigration. It's the GTA, it's Ottawa, it's a little bit around London, and also to some extent agricultural workers in the farming parts of Southern Ontario. So in Toronto, last year our rate was about 11, just over 11 per 100,000. Okay, so last year and this is with many thanks to Public Health Ontario for this data, there were almost 1,000 people diagnosed with TB. Almost all of them were born outside of Canada. But these are not newcomers. These are not, by and large, not people fresh off the plane at Pearson. The median time since arrival in Canada was 7 years. So that's kind of an important piece, that the risk of TB after you come to Canada can keep on going for many, many years. We do have a handful of people who are Indigenous First Nations, but that's very much in remote northern communities. We have a handful of people who are HIV positive, but unlike, the big HIV TB co-pandemics in South Africa, it's not a big driver of tuberculosis in Toronto. It happens, but it's not a big piece. And one of the really interesting parts of it, we were sort of chatting about this at the beginning of rounds, is there's almost like two groups of ages where things show up. For sure, a lot of people with TB are at that elderly end with comorbidities and all kinds of reasons to be immunocompromised. But the biggest group is healthy young people with no comorbidities, no risk factors at all, other than the fact that they're somewhat recently arrived from countries with a high incidence of TB. Which is why, healthy young person with community-acquired pneumonia, born outside Canada, in my head, that's like TB until proven otherwise. So, and very few small children. Those are almost entirely secondary household contacts of a parent or grandparent with tuberculosis. Okay, so TB, so now we're kind of getting closer and closer in. So last year in Toronto, there were 376 people diagnosed with TB. That was the highest count since 2002, I think. And to the point about complexity, a quarter of people are not on standard TB treatment for one reason or another. Either drug intolerance means you have to change things around, or interaction with other meds, often a problem for HIV, or up to 15% of people have a strain that's resistant to at least one first-line drug. That's almost entirely monoresistance to INH. But what that does mean that if we don't have sensitivities, that's a big enough rate that you kind of have to assume that it could be an INH resistant strain and manage it accordingly. About 15% of people don't have OHIP, and almost 30% have temporary immigration status of some kind. So either they're a refugee claimant or an international student or a temporary work permit. So there's lots of issues around access to care and funding for care for folks. As Jessica said, or Rena said, about a third of people with TB in Toronto live in Scarborough. SHN actually pulls from Markham, which has a fair bit of TB, and also from Durham, which has less TB, but it's creeping up. So so Scarborough and SHN are in many ways kind of like epicenter is a dramatic word, but a core of TB and TB care in Canada. So I wanted to talk a little bit more about, so what does the public health side of things do? So why public health is involved is because of the potential morbidity and mortality of TB. It's a reportable disease. And the goal is to make sure that everybody has access to TB care, that people complete treatment, and that we minimize further transmission. So to that end, all TB medication is free through public health, regardless of immigration status or insurance. Every patient with active TB has a public health nurse working with them and their family to sort out things like isolation while people are infectious, the sort of nursing education and support, a lot of collaborative clinical care with the clinicians. We do treatment support, including directly observed therapy. It's hard taking any treatment for a long time. And this is, a good handful of meds for at least 6 months. And they can have side effects. So the, sort of cheerleading and problem solving to get people all the way through makes a big difference in adherence. It's the public health side that manages the non-clinical sort of difficult situations. That could be everything from I can't come to my appointment to start on TB treatment because I'm getting on a plane to India tomorrow night and I spent thousands of dollars on those tickets. That actually happens often enough that we have a form letter for it. We have a social worker with a TB program. And we have never had an airline refuse to let somebody rebook their tickets for free. So all kinds of those pragmatic barriers, the public health nurses and our fabulous social workers can help with. And public health is also the legal backstop. If there is, adherence issues to the point where there's actually a public health danger. Rena mentioned TB Up. That's a provincial program to cover the costs for anything that can be billed to OHIP for people that don't have health insurance. It unfortunately doesn't cover the bed costs for admitted patients, but it goes a long way to cover all the diagnostics and physician care and outpatient care. It's public health. It does the contact tracing and follow-up. We can talk, if there's time, about immigration referrals. And of course, all of the epidemiology kind of flows through from the lab and clinicians through public health to all of those graphs that I showed. Okay, just a little bit about DOT. We try really to frame it more as treatment support because it's not, for most patients, it's really not about policing the meds going in the mouths. It's the practical problem solving and the cheerleading. We start everybody pretty much on DOT in person. If people are medically complicated and it's useful to have a healthcare worker like physically laying eyes on them frequently, we'll keep doing it in person. But we do about 75% of our DOT by video at this point, which is a lot easier for patients if they're, medically and socially stable. What else was I going to say here? Oh, that graph on the right is an older study now, but that was from patients in the GTA who were or were not on DOT and showed a detectable survival advantage to being on DOT. And we think that's really because of the early side effect detection and management if people are on DOT, and being able to monitor treatment response as well. So treatment failure can get picked up much, much earlier. Okay. Speaking of treatment failure, so drug-resistant TB in Ontario and Toronto and Scarborough is again like hugely a reflection of drug resistance around the world. And you can see on this map that the former USSR has by far the highest rates of multi-drug resistant TB in the world. There are lots of former USSR countries where the rate of MDR TB in people diagnosed for the very first time is well over a third. So this is where if you have somebody from, say, the Ukraine who is diagnosed with TB, they don't have a big rate of TB, but 1/3 of people diagnosed with TB in the Ukraine have multi-drug resistant TB. So this again is an example where having access to a great lab and drug resistance testing is critical. So that little bar graph on the bottom is the count of people diagnosed with MDR TB in Ontario. So, for a long time, it was bumping up around 8 or 10. 2022 was kind of a nerve-wracking year, but the counts have come down since then. it's really so dependent on migration flows. If we had another big surge of people from the Ukraine or elsewhere, that could change on a dime. So I wanted to talk at least a little bit about some of the developments in TB drug regimens. I got to say, this is a fantastic time to be working in TB. There were no new drugs developed in tuberculosis for like 30 years. And then in the last decade, 3 completely new categories of TB medications have been not just discovered, but actually put into circulation. So for multi-drug resistant TB, the treatment used to be absolutely awful. 18 to 24 months on at least 7 medications at the beginning, one of which can only be given through IV, terrible side effects, poor outcomes. And in the last 2 or 3 years now, since it was endorsed by WHO, we've been using what's called the BPALM regimen in Ontario. So that's bedaquiline, pretomanid, linezolid, and moxifloxacin. And it's hard to overstate the difference. It's gone from being this really awful, arduous regimen to 6 months, all oral, much, much better tolerated, and with really successful outcomes. The numbers I've quoted there for successful outcomes are from the TB Practical study. We've actually, everybody that we've managed in Ontario on the BPALM regimen has done well. Small numbers so far, but we're shooting 100% at the moment. So that's fabulous. Certainly in the GTA, MDR-TB is pretty much all managed at West Park. There just, fortunately, isn't enough of it for even most TB specialists to have a lot of those cases. And it does really help to have not just clinicians, but pharmacists, clinical pharmacists, and nurses, and a whole team that's familiar with MDR-TB and the medications and management. Okay, I wanted to talk a little bit about new developments in testing. So I borrowed these slides from Angela Ma, who's the MedMicro running the TB lab at Public Health Ontario. The whole thing about testing for TB at the lab side is big and complicated. So this is the simplified version. So we say, 3 sputums or biopsies. You have to, just a reminder, you have to put for TB, which is where, Jessica's example about people who build it into their routine practice is really important, because it's just not going to get picked up, of course, on routine cultures. AFB smear we've had for decades, along with culture and phenotypic resistance testing. 2 big new things have happened within the last year. The first one is the red one at the top. For any samples that are smear positive, the lab does real-time PCR, TB identification, and rifampin and INH resistance by real-time PCR. So that makes a dramatic difference in how fast we can get at least preliminary drug sensitivities. The other big thing that rolled out just a couple months ago is routine whole genome sequencing for every culture, every specimen that cultures, or first specimen. So from that, we can do speciation, we can do molecular resistance prediction, and on the public health side, we can, because all of the isolates are being tested for whole genome sequencing, we can check for matches in the provincial database. And that's incredibly helpful for contact investigations and transmission epidemiology. So this is a little bit more about that real-time PCR. You might hear it referred to as the BD Max assay. So it is validated for a slew of fresh specimens. Those are always going to be the easiest to work with from the lab end. So what that PCR is doing is looking for specific resistance genes, the most common ones for rifampin and INH. So it's still not, is this resistant to anything? It's testing for very specific genes, but it's hugely valuable nevertheless. On the whole genome sequencing side, it becomes much, much bigger. So I've put in the red box there, every strain that cultures, the lab will run molecular predictions, resistance predictions for isoniazid, rifampin, ethambutol, pyrazinamide, moxifloxacin. If there's resistance to those, they'll reflexively look for molecular resistance prediction for second-line drugs as well. So again, incredibly useful. And this is, the genes that they're looking for are based out of a big sort of catalog that WHO holds, that lists out specific mutations which have been linked to clinically significant treatment failure. So again, these are not random. These are proven mutations that infer resistance. So this is what the lab reports look like. And I wanted to show this because the first time anybody looks at these, it's incredibly alarming, because you can see along the left, it's saying the specific drugs, molecular resistance prediction, and then the result, it will say, if things are going well, it will say no high confidence resistant mutation detected. That's good. And then it says cannot rule out resistance, which is where it's alarming the first time you see it. That's really just a reminder that you also need to look at the phenotypic sensitivity as well. So this is the good result that I'm showing here. Okay, another just ticky box, that Scarborough is actually the very first hospital to roll this out, is the use of gene expert machines for de-isolation. So this is more an IPAC tool than a diagnostic tool. So Rena can probably talk a lot more about this, but it's the idea of it is, so long as TB isn't kind of like the working diagnosis for somebody, it can be really helpful to say, well, even if they're later diagnosed with TB, we can confirm that they would be absolutely minimally infectious if the gene expert is negative, and that allows better bed flow management to get people out of a negative pressure room. So very helpful there. There's a bunch of anecdotal other issues that I wanted to sprinkle into the epidemiology part. We've had an increase in neonatal TB in the GTA over the last 5-6 years related to IVF pregnancies. And that's because genital TB globally is a major cause of infertility. So it's kind of like, okay, TB causes infertility. People with infertility go for IVF. And if the TB screening isn't great at that stage, we've had situations where the baby is born with congenital TB, and the mother is diagnosed because of the baby's presentation and turned out to have culture positive endometrial TB, for example. We also every year have healthcare workers diagnosed with active TB disease. Every single one of them had a documented positive TB skin test and no preventive treatment. So we should be able to do this for anyone who deserves, the best possible TB preventive treatment on a silver platter. It's healthcare workers. So something to keep in mind. Another thing that's becoming much clearer is that the TB risk isn't just being born in a country with high rates, it's also visiting. This is especially easy to see in children. Canadian-born children of immigrant families going back to visit grandparents and extended family is a classic way for Canadian-born kids to catch TB. Some more things to think about at the hospital end. We're really good now at keeping people alive with complex comorbidities that are either immunocompromising in themselves or the treatments we give people are immunocompromising. Every single dialysis clinic in Toronto has had TB cases. But this also comes up in HIV, for rheumatology and GI clinics, transplant, diabetes is we don't do systematic screening, but certainly the rate of diabetes and tuberculosis is very high in our Filipino community, for example. So again, Rena could probably talk more about this, but systematic screening in dialysis or pre-dialysis, ideally, and treatment of LTBI can make a big difference for people who have these sort of layers of TB risk. Just a little flash for those of you who know the online TST interpreter. It's been recently updated and it has a fancy new smiley face visualization that helps working with patients. People may know about IGRA testing for TB. It's a single, like a blood draw that does not interact with BCG. And thanks to those of you who wrote in and put comments on for the health technology advisory group that reviewed IGRA over the winter and posted a report recommending publicly funding for IGRA. Hasn't come through yet, but now we know who the new Minister of Health is post-election. So I am very hopeful that will happen soon. And just to say, there's also big developments in shorter, safer TB preventive treatment regimens as well, which is really promising. Okay, we can come back to that if there's time. But I wanted to leave time for Jessica to also do a little update about TB clinical care in Scarborough.
Thank you, Elizabeth. Thank you for that talk. It's very interesting to see, the epidemiology and the new trends in TB. Also, that we're 1/3 of the TB cases is actually very, I don't know, I find it very exciting. I think working at SHN is amazing, and this is one of the reasons that it's so amazing is we get to treat all this interesting TB and cure people. So we are very excited. We're going to start a TB clinic at SHN. We've been developing it over the last couple months. Dr. Susan, John, and myself are going to be the co-clinic leads. We're going to be having a clinic once a week. It will involve both IED and respirology. We've got an Epic build for it now, so referrals will be going through Epic. We will be getting it out very soon. So we'll be treating initially non-contagious TB, latent TB, pulmonary TB on treatment, non-pulmonary TB. And then when we clarify a bit around our access and use of an airborne room, then we will take all referrals, including contagious TB. So very excited. So that should be great. Our dialysis population can refer latent TB to us. Our subspecialists with immunocompromised patients, on a positive TB skin test or TB quantiferon can refer to that. So it should be very helpful for the community.
It's that little map there shows where the other TB clinics are in Toronto. They're all, downtown plus West Park. And if, huge kudos to SHN for pulling off getting this TB clinic in Scarborough off the ground. It's hugely needed, and it's going to make a huge difference, I think, for ability to to manage complex patients and have things be a lot closer to home for people that might otherwise end up being referred to another TB clinic. Huge kudos. Really looking forward to it.
It's gonna be fun. It's gonna be a lot of fun. I think it, Epic makes it nice. We can centralize it. So I think it's gonna be a wonderful addition to SHN for everybody.
Mm-hmm. And we have promised all of the TB clinics have a public health nurse sort of embedded on the team. And we're absolutely good for that for a Scarborough TB clinic. So looking forward to that evolution.
Perfect. Any questions from anyone? I see in the chat there's a link shared for the TB, the TST online tools. So that's nice. Thanks, Eunice, for sharing that.
Jess, it's David. I have a question.
Hi, David.
Did your patient, he grew up in Red Lake. How long did he live in Red Lake?
His whole life. He just recently moved to Tillsonburg, but he was working in the mining industry, married and had children all in Red Lake. He worked with a lot of Aboriginal populations, but he couldn't remember any specific, exposure or anything. He was surprised.
Yeah, no, I'm sure he was surprised. You wonder if how many, growing up in Red Lake. I mean, I grew up in Saskatoon, and half of my class was Indigenous, and that was a big city compared to Red Lake. So I wonder how much contact he had with the Indigenous population in and around Red Lake. And then my second question is, did he get BCG as part of his treatment for his bladder cancer?
I don't believe he got BCG. I reviewed his treatment notes, and I did not see that in his treatment.
Okay.
He would have had a BCG as a kid, though, right? Like, he's old enough that BCG would have been standard when he was growing up.
I don't know about that, Elizabeth. I mean, frankly, he's about the same age as me, and I don't think I had BCG as a kid. Maybe in Red Lake, maybe living in Northern Ontario, however.
Yeah.
It was, at that time, it was still in use. I don't know.
So BCG the provinces stopped it at different points, but broadly, BCG was stopped in the routine schedule in the early 1970s. A little later than that in Quebec, and they still give it in Nunavut.
I don't know. I'll have to ask my wife to look at my shoulders. Maybe I have a scar. I don't know.
Maybe.
maybe I do after all.
Yeah.
Okay. Anyway, that was very interesting. Thank you, Elizabeth, and thanks, Jess. I gotta go.
Thanks, David.
Thank you, Elizabeth. We love public health. Like, you guys, are so helpful to us in Scarborough. So we're very appreciative. And I think, Toronto honestly provides great TB care. Like, it's really wonderful.
Yeah, it's definitely a team sport.
It is. My patients love their public health nurses. They love the direct observation because they identify all the problems. Like, the nurses will email me, my patient had a rash or felt a little sick or whatever. They're just very well cared for, and they really like it.
Good. There's a note in the chat about can you talk about shortening of isolation requirements for smear positive TB? I absolutely can. So the current Canadian TB standards, which is from 2022, did a review of what do we know about how infectious are people after they start on treatment? So the current recommendation says if people are smear negative, they can come out of isolation when you have drug sensitivities, so they're on the right treatment regimen, they're doing well clinically, and tolerating and adherent to the meds. For people who are smear positive, the guidelines say 4 weeks of TB treatment, clinically doing well, the drug sensitivities, they're tolerating and adherent to the meds. Or if they convert their smear in that between 2 and 4 weeks, you could take them out earlier. We used to hold out for smear conversion. And that's because, this is old history now, that's because in the 1990s, there were big, horrible outbreaks of MDR-TB in New York City that bounced back and forth between HIV wards. And at that time, remember, there was no good treatment for HIV. And New York City was in the middle of a massive outbreak of HIV as well. Bounced back and forth between the HIV wards and Rikers Prison. And at that time, it was not routine to get drug sensitivities. So in effect, what was happening is people with undetected MDR-TB were sitting on inadequate treatment on HIV floors, spreading MDR-TB because they weren't on the right regimen. And because of that, the CDC revised the recommendations to say, well, since it might be not until people have been on treatment for 3 months that they would first fail treatment, then you would ask the lab to do this special deal about getting drug sensitivity results. So they said, hold out for smear conversion to avoid this issue of undetected MDR-TB failing treatment. Now we've got initial drug sensitivity results back within 48 hours. It's a very, very different clinical management situation now than it was 30 years ago. Plus, there's hundreds of guinea pigs that would say even as short as 1 dose of adequate treatment is enough to functionally stop transmission. So between all of those different layers and reviewing all the available evidence, that's where the current recommendation came from. So we've been using that in Toronto for a good 2 years now. I will say the piece that can be the most complex sometimes is the part about clinical improvement. Especially if you have, complex, frail, elderly people with a lot of stuff going on, they can respond more slowly. So we have kept people on isolation longer in those situations to be more confident that they did have clinical improvement. But yeah, so that's the current guideline. And for hospitalized patients, just to underline, Rena and her team have the final call on hospital de-isolation. Public health manages de-isolation in the community.
Perfect. Thank you so much. I guess that's 1 o'clock, so we'll let everybody go. But, reach out to us if you guys have any more questions. Thank you, Elizabeth, very much for joining us today.
Thank you too.
Thanks. Have a
Bye,
great day.
everybody.